And thank you so much for joining us for the Suicide and Overdose event, the leading cause of death for new mothers. Thank you again for joining this discussion, and we look forward to having audience participation and engagement. Gentle reminder that this call is closed to the press. Additionally, we will be taking questions after the remarks portion ends, and we kindly ask that you put any questions you have into the Q&A box at the bottom of your Zoom platform. Special thanks to the Maternal Mental Health Leadership Alliance for hosting this webinar, and to the following partner organizations: the American Foundation for Suicide Prevention, Moms 2020 Moms, the National Alliance on Mental Illness, Mental Health America, and the American Psychological Association. Thank you to each of our speakers for taking the time to share their knowledge and experience with us today. While we may use the term mothers and women in our presentation today, we acknowledge that not everyone who gives birth identifies as a woman or with the sex assigned to them at birth. And we hope and always aim to be inclusive of all birthing people, including those who identify as transgender, gender expansive, or non-binary. With that, it is my pleasure to turn it over to Adrienne Griffin, who's the Executive Director of the Maternal Mental Health Action Leadership Alliance, a nonpartisan nonprofit organization dedicated to national advocacy for the mental health of childbearing people in the United States. Adrienne has a master's in public policy from Harvard's Kennedy School of Government and has been a leader in this space for a long time. So with that, turning it over to you, Adrienne.
Great, thank you so much, Eden. And thank you to all of our partners in today's events and to the panelists and for all of you in the audience for taking time from your busy lives to learn about this important information. Next slide, please. So a few guidelines. Remember, only the speakers and the presenters can speak or be seen. Questions will be handled at the end. You can submit them through the Q&A. For any support, you can message tech support in the chat feature, and then the recordings and the slides will be posted to our website afterwards, and look for a follow-up email from MMHLA in America. Next slide, please. Here's a quick overview of who our speakers will be today. So along with me is Rachel Pryor from the United States Department of Health and Human Services, as well as Karen Marks, and Dr. Jametta Nicole Barlow from the George Washington University, and Dr. Karen Sheffield Abdullah from the University of North Carolina at Chapel Hill. Next slide, please. So again, my name is Adrienne Griffin, and I am the Executive Director of Maternal Mental Health Leadership Alliance. We focus exclusively on national policy around maternal mental health. Next slide, please. So as we talk about maternal suicide today, next slide, please, I want to put it into the broader context of maternal mortality in the United States. Many of you, I'm sure, have seen the chart on the left, which shows that the United States has the highest maternal mortality rate of any of the industrialized nations. Maternal mortality rate is the number of deaths per 100,000 births. And you can see from the chart on the left, the red line shows that the maternal mortality rate in the United States has actually been increasing over the last 2 decades. Next slide, please. And as the name of our presentation indicates, suicide and overdose combined are the leading cause of death for new mothers in the first year following pregnancy. And significantly, mental health conditions are the most common complications of pregnancy and childbirth. I just want to sit with that for just a moment. Think about that. Mental health conditions are the most common complications of becoming a new parent, and suicide and overdose are the leading cause of death for new mothers in that first year following pregnancy. Next slide, please. So a few facts about maternal mental health. 1 in 5 women, pregnant or postpartum people, will experience maternal mental health conditions either during pregnancy or the first year following pregnancy. And 75% of those who experience these symptoms actually remain untreated. This puts an extreme burden on our country. The annual cost of not treating these illnesses is $14 billion each year in lost wages and productivity of the mother, and addressing poor birth and poor health outcomes. Next slide, please. And a few facts about maternal suicide. New mothers who commit suicide die most often in the late postpartum period. The peak incidence of suicide is 6 to 9 months postpartum. They often use the most lethal means of suicide. They do not attend a postpartum obstetric visit for the majority, but the majority do visit the emergency department within a month of attempting their suicide. And over a third of those women had a documented suicide attempt. Massachusetts, in particular, has data from their Maternal Mortality Review Committee that shows that 50% of those who committed suicide actually had a documented mental health diagnosis, and that 92% of those were documented prior to delivery. So the healthcare system knows that these women are at risk, and yet for some reason, we are not helping those new mothers. Next slide, please. The last few years have seen a number of significant additional stressors adding to the pressures that new mothers feel. Everything from the COVID pandemic to the infant formula shortage, women wondering how they are going to avoid COVID and feed their infant. How are they going to take time to heal and recover? How are they going to teach their children and keep everybody safe and find reproductive? Next slide, please. So my question is, how is it possible in our country where we spend 20% of our GDP on healthcare? How is it that we are failing our nation's mothers? Next slide, please. The rest of this presentation, you will be hearing steps that our nation is taking to better support new moms, birthing people, and new parents. On Mother's Day of this year, a national maternal mental health hotline was announced, headed up by the Health Resources and Services Administration. This hotline is available 24/7, 365, and provides voice and text services in English and Spanish, along with translation services in 60 additional languages. This hotline provides education and support, brief intervention, as well as information and resources for new moms, new dads, grandparents, anybody who may seem that they are struggling with their mental health conditions during pregnancy and the first year following pregnancy. The hotline is staffed by licensed and credentialed mental health, healthcare, and childbirth professionals, as well as certified peer specialists. And you can learn more about that hotline at the link listed below. Next slide, please. Thank you so much again for being with us. And Eden, I'll turn it back over to you.
Thank you so much, Adrienne, and for your remarks. Now, introducing our next speaker, Rachel Pryor serves as counselor to the Health and Human Services Secretary, Javier Becerra, overseeing Medicaid, CHIP, and the Substance Abuse and Mental Health Services Administration, mostly referred to as SAMHSA for those of you who have worked with us before. Rachel also leads behavioral health issues and strategy across all 11 of the HHS subdivision agencies. She holds a master's in social work from the University of Maryland and a JD from Georgetown University's Law Center. She's someone I have the pleasure of working with and inspired to be like one day. So with that, I'd like to introduce a personal hero of mine, Miss Rachel Pryor. Turning it over to you, Rachel.
Thank you so much, Eden, for that very warm welcome, and that's too kind. I think Eden's inspiring in her own way, so I feel like she's also someone our folks very much look up to and is doing incredible work for us. So I'm really thrilled to be here with you all for a very short time on a topic I care about deeply. I will say one that I'm intimately familiar with. I'm a parent of a 5-year-old and a 2-year-old myself, as I know many of the folks who are listening to this are. And for those of us who have sort of been through that pregnant and postpartum period, I think it's safe to say that the world sort of has, there's an expectation out there that you should be sort of in the prime of your life and happiness. And it's all those feelings sometimes, but it's also the hardest time a lot of us have ever gone through. And it is unbelievably important that we do a better job of supporting pregnant and postpartum people when they are in that stage of their life. It's just beyond important, and I'm really thrilled to have the opportunity to work on this issue. And I do believe we're at a really special moment in time. I'm looking here and I see 836 participants, which is incredible. We are trying desperately hard to get the word out about how important this issue is, how important of a priority it is for not only the federal government to work on, not only the Biden-Harris administration to work on, but for us to support all of you to work and advance support for individuals that are in the pregnant or postpartum period. I want to say a special thank you to Adrienne, and then also to the Maternal Mental Health Leadership Alliance and our co-sponsoring partners, not only for having me join this event, but having this event, right? I think gathering folks together to talk about this issue is incredibly important, from just a stigma perspective to putting the issue out there, to allowing us to learn from each other. So want to say thank you for those co-sponsoring partners. At HHS, I think, as some folks have heard me say before, we have a department-wide commitment to rethink and transform how we are responding to and treating behavioral health in this country. We are talking about two of our department's strategic priorities today. And I will say, for folks listening, HHS is the department that oversees 11 of our agencies. So everything from the CDC to NIH to SAMHSA to CMS is all under our HHS department umbrella. And we have made a commitment to all of our agencies to work together, to work across the country with all of you, to think about both maternal health and to think about behavioral health, and to think about those two things together, which is what we're here to talk about today. Our secretary and a lot of our agency leadership have hit the road to visit our communities on the front lines as part of our HHS national tour to strengthen mental health. So I encourage you to reach out to our IEA team if you have an idea for us to come see you. We are at the 6-month mark of our national mental health tour. I'm proud of the accomplishments our folks have made. I'm proud of the billions of dollars that we have invested over the last year alone. But I want to encourage folks on the phone to keep the pressure up, keep the pressure on us, because I don't want this moment to pass us by without us having taken every single possible opportunity that we can to make life better for people. In May, as Adrienne noted, we launched the Maternal Mental Health Hotline. I want to say a couple words about this hotline because I think it's really important. Providers on this hotline will be trained on mental health during pregnancy and postpartum, right? And our pregnant postpartum individuals will have a national level confidential 24-hour toll-free hotline if they're experiencing mental health challenges. I want to make the distinction between our maternal mental health line and our 988, which a lot of folks know as our suicide hotline, our behavioral crisis hotline, which launched in July. That hotline is for crisis situations, and our maternal mental health hotline do a warm handoff to our 988 hotline if it looks like we have a crisis situation. And so we are trying to, at the federal level, make those various different things work together. But we also know that folks that are in the pregnant and postpartum period have special challenges that they're dealing with, particularly when there's a substance use disorder involved. I want to say a couple words about a few other accomplishments that we are proud of, that we're working to roll out so that folks know a little bit of what's to come. We're thrilled that the Bipartisan Safer Communities Act, our largest gun safety legislation in 2 decades, is now signed into law, and that included a huge amount of behavioral health investments for us as a department, one of which is an additional $150 million into our 988 suicide hotline. This administration has made an 18-fold investment. We were at less than 20 million, I think, a year ago, and thankfully have now hit almost 450 million that we will have invested in the 988 hotline. That's not enough, but it is certainly an incredible start. Mental health conditions for pregnant and postpartum people are incredible. They are increasing. It's just abominable, right? We can do better. We know we can do better. And we are trying to set up the structures and the supports across the continuums that nobody has to feel alone in this period. I mentioned at the start of my conversation with you all, that I'm a mom of two very young children. I'm not too far out of that stage myself, and someone who, like me, who has every advantage a person could ever think to identify, still struggled a lot, and still needed a lot of help, and still needed help during that time. And it is, you know, there's just no end to the amount of investment that we should do here. And so, you know, every parent deserves to have those moments where they can really feel and be with their child for every first laugh, every first smile. They need to feel like in the middle of the night, they are not alone and that what they are feeling is okay. And here, right here in the US, we have too many parents still, I think, that don't feel that. And so our goal, you know, with our maternal health blueprint, which I haven't even gotten to talk about too much, but with our maternal health blueprint is to make sure that no parent ever feels alone. And it really is that simple. You know, we are working across every single agency. So for example, in our Medicaid program, to get every single state to expand that Medicaid coverage for the full 12 months, with our HRSA agency, to roll out and expand the rural maternity and obstetrics management strategies program to more robustly train our rural health providers. And we are working to expand, as I mentioned, 988, our maternal mental health hotline, to ensure that we're doing a special focus on moms that are suffering from substance use disorder. And we're going to keep at it. You know, we're going to keep at it. I do think we're at a special moment in time. I believe that we're at a special moment in time. And I think that if all of us can collectively keep the pressure on, keep folks paying attention to this, that we can look back and maybe we won't have done everything, but we will have done so much, and we will have something to build on, a foundation to build on that I think we can all be proud of. So I want to thank everybody again for letting me have the time to talk to you today, and turn it back over to you, Eden.
Thank you so much, Rachel. We really appreciate your time and your insight there. Moving to our next speaker, I now have the pleasure of introducing another colleague of mine, Ms. Karen Marks, who serves as the Director of Strategic Partnerships in the Office of Intergovernmental and External Affairs for the Secretary of Health and Human Service, Javier Becerra. Karen directs public-private partnerships for the department and focuses on stakeholder engagement on issues related to the Centers for Medicare and Medicaid and maternal health. She earned her master's in public policy from the Harvard Kennedy School and a bachelor's degree from Emory University. With that, it's my pleasure to introduce Ms. Karen Marks. Over to you, Karen.
Thank you, Eden, for the warm welcome. It's going to be a hard act to follow after Rachel, but what I'm hoping to do is go in a little bit more depth on what the administration has done and is doing on maternal health and the intersection between maternal and mental health as well. So the Biden-Harris administration has demonstrated a strong commitment to maternal health over the past 2 years. President Biden issued the first ever proclamation for Black Maternal Health Week in 2021, and then Vice President Harris convened the first ever cabinet meeting to bring together all of the department leaders to identify ways to further address improving maternal health outcomes. In December last year, Vice President Harris also hosted the first ever Maternal Health Day of Action with a call to both federal agencies and the private sector to work together to solve the maternal health crisis. And to complement the announcement of the initial private sector commitments on maternal health, which among the commitments announced included 2 companies that committed to expanding access to mental health professionals and resources for postpartum parents, the White House released the Maternal Health Blueprint. This is a compendium of all the actions across the federal government that can be taken to address maternal health. And I will say, as we were drafting this document, there was a specific call to every agency to say, what can we do more in the maternal and mental health space? And with that, you'll see that in some of the actions and commitments included in the blueprint. So I want to touch a little bit on some of those specific actions. Some of them have already been raised, and I want to highlight a few others as well. There's actually 5 goals in the Maternal Health Blueprint. The first goal is to increase access to and coverage of comprehensive, high-quality maternal health services, including behavioral health services. And under this goal, there's a number of actions related to maternal mental health. The most well-known, two of them actually, is the extension of postpartum coverage for Medicaid moms, that was spoken about by Rachel, as well as the maternal mental health hotline that both Rachel and Adrian covered. Some of the other actions that we've committed to across the administration and under this goal include strengthening access to perinatal addiction services by partnering with hospitals and community-based organizations to implement evidence-based practices, appointing a head of the women's mental health and substance use. So we're going to hire an associate administrator for women's services in HHS's SAMHSA to lead efforts on promoting positive mental health during pregnancy and in the postpartum period. I know we've heard a lot from a lot of the advocates in the space that maternal mental health often falls between all of the agencies. You've got those that cover maternal health, those that cover mental health, and those that focus on maternal mental health. And we're really trying to fill that gap and make sure that we are focusing on this population. Under Goal 1, we also plan to expand the capacity to screen, assess, treat, and refer for maternal depression and related behavioral disorders. And the DoD is actually piloting a reproductive behavioral health consultation service based on the VA's reproductive mental health consultation program. In the second goal of the blueprint, the bigger picture goal is to ensure that those giving birth are heard and are decision makers in accountable systems of care. And under this one, I want to highlight two of the actions that relate to maternal mental health. The first is to reduce the stigma of postpartum depression and other mental health disorders. HHS is committed to engaging in a media campaign that will be launched early next year to raise awareness for women, families, and the general public about postpartum depression and how we can better support families and improve maternal mental health outcomes. We really are working towards destigmatizing maternal mental health issues and making sure that people are able to seek the help that they need. We also have a goal of advancing data collection and standardizing data that is collected. We want to raise this a CDC action that applies here, which is to strengthen the MMRC, which is the Maternal Mortality Review Committee data collection. This is what states have, and that's how they track maternal mortality. CDC is making a commitment to make additional data on population and community level indicators available to all MMRCs, including the number of mental health care providers per 100,000 in a population, so that states will be able to identify where those shortages are and how they can then start addressing the lack of maternal mental health providers. Then I want to focus that we have a goal of expanding and diversifying the perinatal workforce. And the last goal in the maternal health blueprint is to strengthen the economic and social supports for people before, during, and after pregnancy. And under this goal, we really want to address social determinants of health, including mental health. We want to support projects that expand access to maternal mental health and make sure that people are able to seek the help that they need. So while maternal mental health conditions, as you have heard, are the most common complication of pregnancy and childbirth, and these challenges are often stigmatized and don't receive the same attention as physical health conditions, we as a department and an administration are really committed to working on the intersection between maternal and mental health to address these issues, and we look forward to working collaboratively with all of you to do so. Thank you, and back to you, Eden.
Thank you so much, Karen, for that insight and for your time. We really appreciated it. All right, and now next to our next speaker. Dr. Jamita Nicole Barlow is a community health psychologist, women's health scholar, and an assistant professor of writing at the George Washington University in Washington, D.C. Dr. Barlow holds a secondary appointments in the Milken Institute of Public Health and Columbia College of Arts and Sciences, where she's the director of undergraduate studies. She's also the past chair of the American Psychological Association's Committee on Women in Psychology. With that, it's my pleasure to introduce Dr. Barlow. Over to you, Dr. Barlow.
Thank you for that introduction, Eden. And thank you to all the organizers and all of the people who worked hard to bring this issue to light. And I want to thank you, participants. I'm actually going to try to address some of the questions, particularly around measurement, that I see in the Q&A. Go ahead, we can start the slides. Thank you. And so, as you can see, I think they're a little bit off, but that's okay, we'll roll with it. I bring you greetings as immediate past chair on the Committee on Women in Psychology, but I'm also for American Psychological Association, but I'm also a part of their maternal health advisory group, and I'm speaking with some of their words. And so just know that some of this is coming from them. I wear many hats. You can see some of the other things that I'm involved with the Black Women's Health Imperative and the Council on Black Health. So today I want to come with you with my brief remarks to talk around 4 terms: remember, reevaluate, redesign, and reimagine. Next slide, please. And so I know there's a little, it's some of the words at the top are off, but I also want to acknowledge, we're going to start with remember. And I want to start actually with my grandmother. So my great grandmother died giving birth to my grandmother in 1924. So when I think about maternal mortality, I have a very personal relationship with that. It deeply affected our family. In fact, family member took in other family members, 4 kids under the age of 5, including a newborn. And so they joined a family of 7. And so when we start talking about maternal mortality and then also suicide, death, and mental health, we have to talk about what this does to the family. And so the Sankofa bird reminds us to look to the past, to remember, to acknowledge those who came before us, acknowledging the land that we're on, the people who work the land, but also acknowledging the systems that we still are seeing the effects of today. Next slide, please. Next slide, please. And so when I talk about maternal mortality, I often give a history of Black health. Now, part of that, while maternal mortality affects women of all races and ethnicities and all birthing individuals, it's important to recognize that it disproportionately affects Indigenous women and Black women. And so understanding the lived context of people's lives, understanding the intergenerational trauma that contributes to a legacy of disproportionate access to services, to inadequate access to services, as well as disparities and inequities in health. You have to understand all of these things, whether it's the role of women supporting women historically and even today, of people taking community-based approaches to addressing these issues, to the very real policies and practices that have created trauma. And we see the legacies of that. One I'd like to mention is that there was a thing called pregnant women and hole digging. So women who were enslaved, they would dig a hole so the women who were pregnant would cover their tummy, their bellies, and they could still be harmed. They could be hit, they could be whipped. Why is that important? It brings up this level of trauma and violence that is often associated with individuals who experience adverse mental health conditions and adverse risk for violence. And so what we're seeing is this legacy of trauma. And this includes a lot of the things you see here, but understanding that they frame, but help us to remember why we're seeing these disparities, why we're seeing these inequities, and hopefully give us some insight to solutions. Next slide, please. Next slide, please. And so reevaluate. It's important to know, I like to, as a public health researcher, teacher, scholar, what you see here are a lot of resources. And I always like to point people to resources. The one thing that I like to mention is that I take primary prevention to the utmost. We need healthy children. We need healthy individuals who choose to birth later to be healthy. What we are seeing is that there's a rise in the suicide rate, but particularly among Black girls. And I think that we have to think through and reevaluate how we're addressing mental health, not just when individuals get pregnant, but also at a younger age. What is happening in context? How are we managing trauma, managing mental health? And so what we've seen recently in the news are that people are saying, well, it's just this one group if we correct for that. And so it's not so much about correcting for that, but it's more about if we centered marginalized groups' experiences, which Black feminism and womanism teaches us, then what we can do is address the maternal mortality rate, maternal health, and maternal suicide. And we could see a difference. We now know that maternal suicide is responsible for more of what we're seeing in terms of death than, say, preeclampsia and other hypertensive conditions. That's major. And it doesn't start when individuals are pregnant. It starts at a very deep analysis of the lived experiences of people of color, particularly Black girls and other birthing individuals. And so what we do need to understand is that there simply aren't enough mental health professionals at the moment. There aren't enough mental health professionals to meet the high demand that we're seeing today and that we're seeing and projected for the future. Why that's important is because the mental health professionals are worn out. They're burnt out as well, like other healthcare professionals. And so what we need to do is find different ways, redesign and reimagine different ways. Next slide, please. So how can we do that? Well, we have to also understand that when we redesign, a lot of the recent studies have looked at perinatal mental health, but you know what? A lot of them don't always include people of color in their sample, or the studies that they're taking from don't include people of color. So there's a lot we don't know in terms of what's happening based on race and ethnicity and other demographics. And so why that's important is that we need to remember and go back to community-based approaches and think through how we can create and fill in the gaps of what we are seeing are disparities. And so these are just some of the articles that are recent on the left that speak to this, that are talking about things we can do at the policy level, at the practice level. And we're seeing that with the new initiatives that were described by the Biden administration. But also we need to redesign and listen to marginalized groups, listen to Black women, to understand what's happening. People know what they need, and create community-based strategies. Next slide, please. And so when we reimagine the health of birthing individuals, I'd like to draw your attention to some of these articles. I co-edited a special issue on Black girls and women's health, and in it we talk about ritual. Every culture has rituals. We know that historically rituals have been a way for us to manage our mental health. So when we're thinking of solutions, let's reimagine different ways. The same way we've been reimagining correcting algorithms and health disparities and formulas, let's reimagine how we're looking at this. Because the reality is there are measurement issues. How we looked at in terms of how people are calculating maternal death, it differs depending on what state you're in. It differs depending on who's examining the data. It differs in terms of how they go back and look at how that individual died. And so we're seeing a move towards a standardization of practice. But while we're doing that, we can also be doing and conducting community-based approaches, including ritual. There's an example of ritual through healing, through hair, through dance, as well as institutional strategies. And this is not new. In 1938, the Mississippi Health Project did work just like this, engaging other community-based approaches and people in community working with one another. Next slide, please. And so I want to leave you with resources. There are a bunch of resources. They're listed here on the left. I'd also like to mention that the American Psychological Association offers continuing education courses, as well as several toolkits and with our partners, some of whom you see listed on the left. I also encourage you to contact APA if you have additional questions regarding some of these tools. And I thank you for your time, and I look forward to questions later.
Thank you so much, Dr. Barlow. And with that, I would like to introduce our last speaker in our panel discussion or panel series for our remarks, and that is Dr. Karen Sheffield Abdullah. She is an assistant professor at the University of North Carolina at Chapel Hill School of Nursing, where she researches culturally relevant interventions to reduce disparities in stress-related adverse outcomes during the perinatal period, with a focus on improving wellness throughout the lifespan. She holds a PhD in nursing from UNC a Master's of Science in Nursing from Yale University, and is a certified nurse midwife. And finally, and all of the other free time that she has for this, Dr. Sheffield Abdullah is also a mindfulness instructor. And so with that, it is my pleasure to turn it over to Dr. Sheffield Abdullah, or as I should just say Superwoman, because she's doing so much to try to save the world. And so turning it over to you.
Thank you, Eden. And so just a pleasure to be able to talk to you today. And thank you for that introduction. We've already highlighted that I'm an assistant professor at UNC Chapel Hill. I've been a nurse midwife for 18 years, and my research really examines and explores stress and anxiety in perinatal African-American women and impact on their birth outcomes, in particular preterm birth and low birth weight. But today I'll be speaking to you to highlight the work that has been done with maternal mortality review committees and the recent data that shows that maternal mental health conditions, in particular suicide and overdose related deaths, are the leading cause of death. And so I served as a nurse abstractor with the North Carolina MMRC and worked on the maternal death cases related to overdose. And I'll be sharing some of that data with you that we have from our state, but certainly we know that what we found in North Carolina has also been echoed across the other MMRCs across the nation. And I want to acknowledge that the work that I'm presenting to you today was funded by the Centers for Disease Control and Prevention and the Rapid Maternal Overdose Review Project. And so next slide, please. So really just to kind of bring us all onto the same page and orient those who do not know what MMRCs are. They're maternal mortality review committees that are multidisciplinary committees that convene at the state or local level to comprehensively review the deaths of women during or within 1 year of pregnancy. Within the MMRCs, we have access to clinical and non-clinical information to more fully understand the circumstances surrounding each death and to develop recommendations for action to prevent similar deaths in the future. Next slide. So just wanting to talk really briefly about the classifications that the CDC uses as we think about deaths occurring during pregnancy, childbirth, and the postpartum period. There are 3 separate categories. They talk about pregnancy-related deaths, pregnancy-associated but not related, pregnancy-associated but unable to determine pregnancy relatedness. Next slide. In particular, I want to highlight pregnancy-related death, which is defined as the death of a woman during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. Next slide. So as we think more broadly about opioid use during pregnancy, according to 2019 self-reported data, about 7% of women reported using prescription opioid pain relievers during pregnancy. And of those, 1 in 5 reported misuse of prescription opioids, which are defined as getting them from a non-healthcare source or using them for a reason other than to relieve their pain. Next slide. Furthermore, we know that the number of women with opioid-related diagnoses documented at delivery increased by 131% from 2010 to 2017. Next slide. So as we think about what we found in particular with the North Carolina Maternal Mortality Review Committee, what we know from the 2016 data, which has been reported, and so I'm talking about that data that we have already published, 92 women in North Carolina died while pregnant or within 1 year of pregnancy in 2016. And a quarter of those maternal deaths were due to overdose. Next slide. Furthermore, when we look at pregnancy-related opioid deaths, we found that at least 38% of those who died from opioid overdose had a history of incarceration, and we were really intrigued by that number. Next slide. So what we did is a qualitative analysis of the 2016 narrative data, which revealed that a history of opioid use disorder was associated with systemic barriers to receiving optimal prenatal care. Next slide. And so just some of the systemic barriers that I want to highlight to you today. poor coordination of care for those who have a history of incarceration, housing instability to include homelessness, meaning that as we think about these individuals when they are discharged or sent home from a jail or a prison, we have not really set up resources for those that are unstably housed once they're sent home from jail or from prison. Also, we noted that there was a lack of adequate referral to a specialist after medication prescription. So we prescribe a medication and then we don't refer them out for further care or for maintenance of their care, right? And so these are some of the barriers that were encountered by these individuals. Excuse me, next slide. So what are the recommendations that the MMRC, the North Carolina MMRC, brought to highlight, right? And so we thought about OB providers ensuring access to naloxone for individuals with a history of substance use disorder, and furthermore to their families, so that they have access to a prescription for naloxone or to naloxone itself. What we also recommended is that universal biological testing is not recommended and should not be used as the sole assessment of severity of substance use. For example, if using urine drug testing, it needs to be done with the person's consent and in compliance with state laws, according to ACOG in 2021. Furthermore, we know that providers need to be more knowledgeable about local substance use treatment resources in the community to assist patients with referrals. There's really a gap there. Next slide. We also talked about OB providers ensuring the scheduling of postpartum follow-up appointments for individuals who have a history of substance use disorder. The 6-week appointment is not appropriate for following up. We need to be seeing these individuals much sooner than the 6-week appointment. As we know, many 6-week appointments are missed. And if the appointment is missed, to really tailor care to the individual with substance use disorder, office personnel should be following up for rescheduling attempts. And also, as we think about OB provider education, which includes all learners, physician assistants, nurse practitioners, nurse midwives, and our OB colleagues, these programs should include substance use education and encourage our OB providers to go through training to obtain their X waiver. And it is brought to my attention that in June of 2022, there was a act that was passed in the House of Representatives that says that the X waiver that eliminates the need for clinicians to apply for an X waiver from SAMHSA, but that it still requires 8 hours of education and training for our healthcare providers. And so with that, I'll stop there and take any questions that we may have in the Q&A portion. Thank you so much for your time.
Thank you, everybody, for being with us today. And Lee's just got a final few words.
Okay, so wanted to say, next slide, tonight our Partner 2020 Mom will be hosting a remembrance vigil for mothers who have died by suicide. So you can visit their website to learn more. Next slide, please. You can see that's happening tonight at 5:30 p.m. Pacific time. Next slide. We also wanted to share some legislation that is being considered that everyone may be interested in. This is legislation that would help with suicide prevention and also to help support pregnant and postpartum people. And we hope that you'll look more into these when we send out the link to the slides. Next slide. And if you want to get involved in advocating for better maternal mental health policy, please visit our website and our partners' websites. And you can see we have links to Twitter accounts and to links to take action pages here, and you'll be able to access that once we share the slides. I wanted to say again, next slide. Thank you again to our wonderful speakers for taking time to speak with us today. Such wisdom that we had in this virtual room with us. I really appreciate that. And the incredible questions from all of our attendees. we couldn't even get to all of them. So like I said, please email me, or you can email HHS directly. I put that in the chat, so feel free to save that and send us your questions later. We're going to send out a follow-up email that will have a link where you can access the recording. It'll just be the speaker remarks and not the Q&A. And then you can also access the slides. As someone who has a 2-year-old and experienced suicidal thoughts at 7 months postpartum, this is such an important topic that hits so close to home. And I'm just really grateful for all the people who are interested in supporting pregnant and postpartum people who are experiencing perinatal mood and anxiety disorders. We need a community to wrap our arms around these new parents. So thank you for being part of that community today. We appreciate you all so much and hope that you have a great rest of your week.